Here we go, Dr. Barnes here, part 2 of the antipsychotic lecture. This is where we go a little bit further. It gets a little bit more complicated, so buckle up. So we're going to go into side effects and another set of receptors, another system called prolactin. Let's start there. The biggest and most important thing to understand about the prolactin system as it relates to antipsychotics is that dopamine in normal physiology has another name, and that name is called prolactin inhibiting hormone or prolactin inhibiting factor. I just really need everybody to understand this, that dopamine literally equals prolactin inhibiting hormone. Meaning in normal physiology, the reason folks are not lactating, etc., from prolactin is that their dopamine is actually inhibiting it. Now, what did we say about all of these antipsychotics except for 3? We said that they all block dopamine. So if you're blocking the prolactin inhibiting hormone, dopamine, then you're inhibiting the inhibitor and you get an increase in prolactin. So I need you to understand that a side effect of these medications is increase in prolactin and everything that comes with that. The most common early symptom is amenorrhea in females and impotence in men. Later you can get galactorrhea. So if you understand that, then we can go into a clinical scenario where this becomes very relevant. It's very important to understand that sometimes you can start an antipsychotic, let's say risperidone, which if you guys remember is a done, which means it's a stronger D2 receptor, which means it would block dopamine stronger, which would further increase prolactin. So if you do a blood test and somebody has prolactin and then you realize you have to take them off of the medication, you take off the medicine, you wait until the medicine is out of the system, you repeat the prolactin level and you realize it went up further, even though there's no more of the medicine in their body. And they want clinicians to understand what the next step in management here, and you may be surprised to know that it's actually a scan of the brain. Because if you start an antipsychotic and prolactin goes up, you remove it, and prolactin continues to go up, it wasn't the antipsychotic that did that, and it could be that you have a prolactinoma on your hands. So you would have to do an MRI without contrast, potentially a CAT scan, something like that. You could tell the radiologist what you're looking for, and you can try to rule out a prolactinoma. Prolactinomas are most likely microadenomas, so you actually would not get the visual disturbances until later when it becomes a macroadenoma. Then you can get bilateral hemianopia, but the amenorrhea and the impotence would be the early symptoms. Hope you guys got all that. Now, if you remember, they all block D2 except for the 3. So what I just told you about prolactin will not apply to these 3 because these are partial dopamine agonists, which means dopamine will partially be increased. So if you remember that, then you know that dopamine will start inhibiting prolactin. So these 3 have a net decrease in prolactin, and that is very important to understand. Moving on. We need to talk about what happens when you block D2 receptors further. Remember, I said you get something called EPS, and the first one we're going to talk about is an acute dystonia. Oh, it's so cute. Acute dystonia. You could read that. And the take-home point here is that there is an inverse relationship between dopamine and acetylcholine, believe it or not. If you guys remember, acetylcholine does a lot of things. And one of the things it does, it goes to the neuromuscular junction, it connects to sarcomeres through calcium coupling, and long story short, it causes muscle contractions. So this acute dystonia means certain muscles will contract in the body. It can happen in any muscle group, guys. I need you to understand this, any muscle group. But for some reason, it tends to happen from the muscles from the neck up. So if you remember the sternocleidomastoid muscles, the largest nut muscle in the neck, and if that contracts, you'll actually get something called torticollis. Okay, the masseter muscle, if that contracts, it actually, you may think, is this tetanus or something similar? It is not. It is actually a dystonic reaction of the masseter muscle. The hypoglossal muscle in the mouth, if that contracts, the tongue moves, it actually sticks out a bit, and you may think that, or the patient may think that they have an allergic reaction, but it's not. It's actually a dystonic reaction of the tongue. Moving up, the eye muscles, there's the rectuses and the obliques, and their eyes can start moving in directions that are involuntary and that they didn't anticipate. And that's called an oculogyrocrisis, okay? And these are things that, unfortunately, we see. So if you understand that these dystonic reactions are from an inverse relationship between dopamine and acetylcholine, then you could understand the treatment because you need less acetylcholine, you need an anti-acetylcholine, you need an anticholine, you need an anticholinergic. The most inexpensive and readily available anticholinergic in America at least, is Benadryl diphenhydramine. So very often that's going to be the treatment for dystonia is Benadryl diphenhydramine. Other options are benstropine, also called Cogentin, and trihexyphenidyl called Artane.